Thank you for joining us today. Hi, I'm Dr. Renea Sturm at UCLA, and I'm a pediatric urologist. Now, a pediatric urologist is a surgeon who cares for children who have illnesses or congenital anomalies that affect the urinary tract. Here on this image, you can see the anatomy that I care for primarily. So you see up at the top here the two kidneys. You also see the two ureters heading down to the bladder, as well as the urethra and genitalia. Today, we'll talk about robotics in pediatric urology. We'll start with a demonstration video that's suitable for all ages. It's a video that demonstrates the Vinci robot. It was designed for children who may be undergoing surgery, as well as their parents. Then we'll cover an example of a patient story. This patient has a common condition that leads to robotic surgery called UPJ obstruction. We'll discuss the case, testing, and follow-up that may occur, as well as the range of effective available surgical options. Finally, we'll end with a surgical video that will illustrate a robotic-assisted laparoscopic pyeloplasty. Feel free to send any questions that you have as we go through below this webinar in that section, or on Twitter at UCLAMDChat. All right, we'll start with the first video here just to give you an overview of robotic surgery. With robotic surgery, we have now the precision and ability to see in 3D using fine movements that are assisted with the robot. Here's our belly, and you can see the little bear inside here. The way that we'll do this, we'll start by inserting a camera. And we do this usually in just near the belly button so that it's hidden. And we put the camera inside. Take a look. There he is. Okay. Once we've done that, we can insert our other two instruments that allow us, through little incisions on either side, to move things around and perform our surgery. Here's one instrument. Here's our second instrument. This is where the surgeon actually performs the surgery. You'll see down here at the bottom where I put my hands, and when I pinch here, I can actually move my arms in a manner that like I would use my wrist to perform a procedure. As you can see here, our Bruin bear has a little bit of a hole in his jacket. I'm going to show you how our robot can perform a procedure to close this very easily. We could suture like this no matter what we were closing to allow us to fix the problem. I hope I've shown you how robotic surgery is assisting surgeons and helping patients return home with less pain sooner after a successful surgery. All right, so hopefully that gave you a quick overview. We'll start with our case now. So this is actually a prenatal consultation. So it starts meeting a woman who's in her third trimester of pregnancy. The karyotypes demonstrated 46XX fetus with antenatal hydronephrosis, and I'll describe what that means in a few minutes. So she's had ultrasounds in her second and third trimesters, and on the side of the screen here, you can actually see the anatomy scan at 20 weeks. And so what you see is you see initial initially a long view of the fetus. You can see the spinal cord right here. The kidneys live on either side of the spinal cord. And then in a transverse view, so across this way, you see either kidney and you see a dark area inside. That dark area is consistent with fluid that's on the kidneys. That urinary tract dilation is what we mean when we say hydronephrosis. So what you see here in that initial image is you see moderate hydronephrosis for the second trimester, which is 8 millimeters, APD on either side. In the third trimester, there's been some increase in that hydronephrosis on the left, but a decrease on the right, and she remains with a normal amniotic fluid index. So her early postnatal course, full term, healthy little girl was born. Her name was Ava, and she's seen in urology with me at 2 weeks with an ultrasound. She continues to have left moderate hydronephrosis, which we would grade as either SFU grade 3 or in the UTD classification a P2. She has 1.8 centimeters APD, which is the anterior posterior dimension of this renal pelvis, which is the exit of where the urine exits the kidney and enters the ureter. There's no ureteral dilation distally. The right kidney continues to have mild hydronephrosis. She's placed on prophylactic antibiotics as she proceeds to her workup. So again, what is antenatal hydronephrosis? So this image helps to demonstrate this. It's urinary tract dilation. It's actually pretty common. We see it in 1 to 2% of all pregnancies. And as you see here, this is a normal kidney. This is a dilated kidney. And you can see within the kidney, there's some dilation of what we call the calyces. There's also some dilation of the renal pelvis. This is the ureter. In this particular image, we don't see it dilated. And then here's the bladder. So what can cause it? So some of the things I mentioned when I see these parents and their children, the most common etiology is actually physiologic, which means most actually resolve on their own without requiring any surgery. It's important to follow them because often, regardless, it's asymptomatic. And the physiologic hydronephrosis often results in just a congenital relative narrowing at the UPJ. Some of these children, however, have a physiologic obstruction, and that obstruction most commonly occurs at this area where the pelvis connects to the ureter, called the UPJ, or where the ureter connects to the bladder, called the UVJ. There can also be an outlet obstruction, such as can occur in boys with posterior urethral valves. Another common etiology would be vesicoureteral reflux. That's where, as we see the urine fill the bladder, it heads up towards the kidney instead of all coming out and when we void. That can increase our risk of kidney infections because, as you can imagine, if any bacteria ends up in the bladder or you end up with a urine infection, that can readily lead to a kidney infection or pyelonephritis. Other etiologies, such as MCDK, are less common. Studies to sort out the diagnosis. So what do we talk about? What might help us figure out not just that the child had hydronephrosis, but what may be causing this? One would be a VCUG, and this is a fairly common study that we may obtain, especially with more moderate to severe hydronephrosis. This is where we fill the bladder, we place a tiny little catheter in the urethra, and we fill the bladder with contrast dye. This is done in radiology so we can obtain some X-ray images, and that allows us to evaluate the urethra for structural anomalies as the child voids, as well as for vesicoureteral reflux, because as the bladder fills, we can see if that contrast goes up toward the kidneys. We can also obtain a nuclear medicine scan. Remember, this is something to be decided with your doctor and for each child individually. Not every child needs all of these tests. A nuclear medicine scan, also called a Lasix renogram. What we give is a radioactive tracer via an IV, increase the urine output with a medication called Lasix. And X-rays are obtained to describe the differential function between the kidneys, so we see the uptake of that tracer in the kidneys, and then we also see it wash out as the body eliminates it, and we can determine a location of an obstruction potentially and how well those kidneys filter and produce the urine. Additional studies that may be obtained include a contrast-enhanced ultrasound or an MRI. Now I put this up here. This is actually from a consensus statement that a panel of experts developed to help guide practitioners in how we might manage these children. And so really this is the mild hydronephrosis, more intermediate and severe. And this is just an overview of what's recommended. Now, I point this out in part to point out how often you see discretion of clinician here, and to point out that there are many varieties in these congenital conditions, and it's very important to discuss those with your doctor. In the most severe findings, we do tend to provide antibiotics and complete further testing a bit more quickly, as you would expect. So Ava, from infant to toddlerhood, she's doing very well. She's had a VCUG as an infant. That showed right here that she has no vesicoureteral reflux. So you see her little bladder here within her pelvis. It's nice and smooth. She's voiding right here, so the urine's coming out as it should. And then you don't see any of that contrast heading up towards the kidneys as you would see if she had vesicoureteral reflux. You also see that she continues to have moderate hydronephrosis with dilation of the renal pelvis on the left. The right actually resolved over time, and the ultrasound continued to be repeated each few months as she came in for her follow-up visits. Now at 18 months, there was noted, unfortunately, some increase in that hydronephrosis. Again, remember, this doesn't happen in all children, but these are some of the reasons that they may require surgery. So in this trial, there was an increase in the hydronephrosis. You can see increase within the kidney of the black area. And then even more important to me as a urologist is you start to see some thinning of this meat of the kidney, or the parenchyma. That concerns us that potentially that could, over time, affect the function of the kidney. And so we obtain a MAG3 Lasix renogram. This demonstrated a slightly decreased differential function, or less on the differential function on the left versus on the right, so 40% versus 60%. There's also delayed drainage, and we see that delayed drainage just extending to that UPJ. So at 20 months, in summary, she's a healthy girl. She's had right resolved mild hydronephrosis, but on the left, there's been some increase over time, concerning, particularly regarding the differential function, as well as that thinning of her parenchyma. She has had no UTIs. Overall, she's asymptomatic. She's eating. She's growing well. She's never had any pain, any vomiting, any masses due to this. But we do recommend surgical correction of obstruction due to the concerns that this could affect her kidney over time. So that brings me to my potential indications for pyeloplasty. What are those? So you've seen some of those with Ava, and some of those could be our radiographic findings. So ipsilateral evidence, so on that same side, evidence of a UPJ obstruction, especially if there's decreasing differential renal function. So sometimes children will obtain a couple of these nuclear medicine scans. Hydronephrosis only is what we're following on that ultrasound. We don't get that information of the renal function on that alone. So they also can have increasing hydronephrosis. It can become more severe. That may also lead us to obtain that nuclear medicine scan. Bilateral UPJ obstruction, of course you can imagine if it's affecting both kidneys, particularly if severe, that can push us towards a pyeloplasty sooner. Clinically, rarely do they have symptoms early on with antenatal hydronephrosis, although sometimes I see teenagers later in life who are having a related condition called an intermittent UPJ obstruction that can be having pain, they can be having stones, potentially recurrent UTIs, rarely causes hypertension or hematuria. So, how many of these children really require intervention, and when might it occur? So, this is a great study out of Canada, and this actually followed a number of children, about 322 patients. They had isolated hydronephrosis, so just like Ava, they didn't have dilation of the ureter, they had dilation within the kidney. What you see is that their mean age when they underwent a pyeloplasty, when it was required, was about 18 months, so a lot like Ava. Cumulative pyeloplasty rates, so this means if we project out how many may require a pyeloplasty over time, if we look at the mild cases, we're seeing only 5%, so it's safe to follow them. Additionally, one of the reasons that pyeloplasty rates have decreased in the US over recent years is that we're understanding that even in the moderate to severe cases, some children will improve over time and not require surgery, some children will develop symptoms or have increase, leading them to have a pyeloplasty performed. So what is this surgery? The surgery is called a dismembered pyeloplasty. And really, it doesn't matter so much the approach. This is the most common way that we perform the procedure. So it was described many years ago in 1949 by Anderson Hines. And you can see here an illustration of what's performed. So the two most common etiologies of a UPJ obstruction, in the smallest child, it's what you see here, or congenital narrowing of the ureter as it connects to the pelvis, such that the urine doesn't drain out of the kidney as quickly as it should, and you get some backup. The other etiology that we see a little more often in maybe teenagers or adults when they start to have intermittent pain is a crossing vessel across this area that may cause some intermittent kinking. Now, you can imagine how either would be suited to this surgery. So we find the enlarged renal pelvis, we incise that. We find either the blockage or the area where that crossing vessel is. We also are able to incise the ureter down to that area, find a normal area, bring that up to a dependent position on the renal pelvis, and then complete the pyeloplasty to help it drain more appropriately. So what are the approaches that we can use? So there's an open approach, there's a laparoscopic approach, and there's a robotic assisted laparoscopic approach. I'll talk about each of these, and really I want to start out with a recent meta-analyses. So this means when we put all those studies together that have been performed, they really show no difference in success or safety, though there are minor differences between each that may help a surgeon choose with the family that which one would be more appropriate for their child. So first, looking at the trends in the United States. So there's this paper that recently came out that looked at the trends from 2003 to 2015. So you can see across the United States, there's a couple of important findings. Remember I mentioned that pyeloplasty rates have decreased over time. So if you just look at the number per year in children, they've decreased in recent years. And that in part is due to our better understanding with series that many of these can be followed. The other finding we have is that you see here the green is robotic, red laparoscopic, blue is open. Initially, early on, when the robotic surgeries were being described and learned, they were less commonly used. However, they have been fairly recently and quickly adopted as surgeons become more comfortable with robotic surgery, and families have this more often as an option. So in more recent years, this would be the proportion of robotic. Laparoscopic has decreased, and then open as well. And really open surgery overall has decreased even faster than the robotic numbers. So open pyeloplasty. One of the benefits is that it has a long history of success. This is that classic Anderson-Hines pyeloplasty that was described. It's successful in 90 to 100% of cases in most series. In the US between 2003 and 2015, that series that I just showed you, open was the most common approach, particularly in infants, so less than 1 year old. Versus as children age, there can be even more benefit to having a robotic pyeloplasty in terms of length of stay and pain, and so more of those children are undergoing a robotic approach. Pros, it's the lowest hospital cost. It still overall has a median length of stay that's very short, especially in infants, a couple of days. And decreased case length, so especially again in infants, there can be, because of the robotic setup, a slight increase in the case time overall. So what is an incision for an open pyeloplasty? So there's a couple. One, and this is the back of the infant, the belly right here. And so underneath the rib, subcostal or flank is a common incision that we might use. Another one would be called a dorsal lumbotomy, and that's approached from the back because the kidneys, remember, live just on either side of the spine, especially in a small infant. So here you can see as we're looking down into that, say, 2.5 centimeter, 3 centimeter incision, you're looking in there and you can see the renal pelvis. It comes right up there as it's dilated, and the ureter, and that can be reconstructed in that way. So what's minimally invasive surgery? So this is laparoscopic or robotic assisted laparoscopic surgery. Initially, the pyeloplasty was described in adults, and it's been further applied in children after that. So in adults, it was found to decrease the pain narcotics requirements, have lower pain scale, the reporting of pain, shorter hospitalizations, and smaller incisions with improved cosmesis. Laparoscopic procedures, when I talk about that, that's what it looks like when we're performing a laparoscopic surgery. So someone's holding the camera, we have a couple of instruments, they're kind of like chopsticks, and we're in there performing the surgery with that. Here's our robotic surgery right here. Same idea, you have these small ports, and you have the instruments inserted in those ports, but the surgeon is sitting at a console and controlling those instruments from the console. So what do the incisions look like? You know, families want to know, you know, in a few years, what are these going to look like? And scars do grow with children. So here is the surgery if we look at an open pyeloplasty. And these are a few years later as we see the procedures and the scars develop. And this would be a very classic incision for, say, infant pyeloplasty and what those might look like over time. This is a secondary approach that's sometimes used called a HIDES, where we can put those two ports in a lower location to hide them even more, but I wanted you to have an overview of what that would look like. So laparoscopic pyeloplasty. In pediatric urology, this has been in use since the 1960s. It's less commonly used when robot is available for reconstructive procedures requiring suturing, fine control. Pros could be that we can use slightly smaller ports versus what's available right now with the Da Vinci, particularly with the Da Vinci Xi, or if there's some limitations on the port length for the small sites within an infant. Haptic feedback means that I can actually feel as I'm moving the tissue because I'm right there with the patient and I'm moving the instruments within the patient rather than away at a console. Minimally invasive option, it is available in the absence of a robot as well. So robotic assisted laparoscopic pyeloplasty, this was the first index robotic case in pediatric urology, meaning this is one of the first ways that the robot was used in this population. So 3D imaging, that's a benefit as a surgeon. I love performing the surgery in 3D rather than in the 2D environment of laparoscopy. Articulated instruments, this means that it moves, the instruments move like my wrist would move when I'm using the robot. There's also a shorter learning curve versus laparoscopy. For a surgeon, we can translate many of those same techniques we learned in open surgery directly into robotics. It's also rapidly becoming the most common approach in the United States. As you saw on those graphs, the robotic-assisted laparoscopic pyeloplasty now comprises greater than 80% of minimally invasive pediatric pyeloplasties, and at this point, it's about 40% of the U.S. total in children. It is expanding to infants, and a recent multi-institutional series demonstrated equivalent success to what we would see in older children or adults, or even in the open procedures for infants. Now, in comparison to open or laparoscopic procedures, pros could include shorter hospital stay, less use of pain medication. Now, this depends on the series and it depends on the age of the child a little bit. And the reason I point this out is because many parents come to me and they ask, you know, this is being recommended, and I start with, these are all very successful procedures. And in the right hands, all of these can have great outcomes. They also have low length of stay overall. So if you look at, maybe I have a national series that there is a small significant difference in the length of stay, but that might be the difference in 2 days open versus a little under 2 days, or maybe a 10% difference with robotic surgery. There's cost savings to parents, less time off work. That has been shown, and some of that involves the post-hospital care, that these children do tend to recover a little bit more quickly. Parental satisfaction has also been shown to be higher, even with equivalent success rates versus the open procedure. Cons, though, do include that it can be a slightly longer case length, depending on the surgeon experience versus open, and higher hospital costs can be prohibitive in certain centers. And we'll go ahead and play the video now. This is a demonstration of a pyeloplasty. So I'll just very quickly go through. So this is in the operating room. It will bring down so here's the renal pelvis. Here's the ureter, dissecting out that ballooned out renal pelvis. And then it's opened there. You can see that urine has been under pressure there, and it's being released as it's incised. That is that renal pelvis being incised. It's being incised down to this ureter. This is actually an infant pyeloplasty right here. Here's that blockage, so that's being opened and dissecting the ureter free, opening up over the blockage. And you can see how it starts to just open for you nicely. That ureter is being brought up to the renal pelvis with the suturing. The one side's been run, and so that abnormal part is removed. A stent is placed, and this is passed right into there to help it as it's healing. It'll be removed later. And then it's closed, and the pyeloplasty is completed. All right, so in summary, pyeloplasty and minimally invasive surgery. So Ava was a 20-month-old girl. She had UPJ obstruction, planned pyeloplasty, was performed, found what we expected with the congenital narrowing at the UPJ. There are a range of options available and effective for pyeloplasty. This includes robotic pyeloplasty, and it's an option for children of varied ages at this point. Pediatric robotics affords many of the same benefits to the surgeon and patients as it has in the past in adults. There's 3D visualization, precision, and accuracy in that small space that's wonderful actually in pediatric cases. There are excellent outcomes, few complications, and improved cosmesis for these children. Thanks for watching. We'll go ahead and answer some questions now. All right. So, discussing a few other procedures in pediatric robotics. So I did discuss one that has the longest history in robotics, but there are many other options and cases in which it can be very useful. One in particular is where a child, say, is born with a couple of ureters and they have what's called an ectopic ureter. So that ureter is dilated and it's not draining well, or potentially even is causing incontinence if it's beyond the urinary sphincter where it inserts. And so what we can do is we can take that one ureter that's abnormal and bring it to the other ureter in a procedure called a ureterostomy, and that can both solve the concern with the incontinence and it can also address the blockage and allowing it to drain normally. Now those are kind of upper tract procedures. That can include any procedures on the kidney, the ureter. We also can perform some procedures that are lower in the urinary tract, things like a ureteral reimplant for vesicoureteral reflux, even some channels and some other reconstructive procedures for children with complex anatomy where we might be trying to pass a catheter to drain the bladder regularly and we don't want to have to pass that through the urethra. So there are many potential options for pediatric robotics. So another question, what does a typical period or post-op course look like for kids with pyeloplasty? And I think we discussed just the times. That's a great question. We discussed just the time for those couple of days, but what's really happening during that time. So, starting before surgery, the parents come in with their child that morning. I talk to them. They also meet their anesthesia team and the nursing team and everyone who's going to be caring for their child before the procedure. We go ahead, a lot of these cases I didn't talk about, but we might perform what's called a cystoscopy within the operating room and a retrograde pyelogram. This can help us really delineate the anatomy right before the procedure. Then, they have their robotic procedure. They go to recovery, meet their parents there, and they're taken to the pediatrics wards. Usually it lasts about a day or two. It's amazing how resilient children are, and that's one of the benefits and wonderful things about performing pediatric surgery. In that most of these children, they're drinking right away in a couple of hours, and they can resume their regular diet very quickly, either later that day or the next one. We start them on a regimen of Tylenol and usually ibuprofen or Toradol, so those are anti-inflammatories. They can also have some narcotics as needed, and occasionally there's some additional medications that can be used, but primarily these children are going home the next day after surgery. Okay, concurrent procedures with a pyeloplasty. We talked about one, which would be the cystoscopy and retrograde pyelogram. I do think that another one that we can perform that's benefited by potentially the robotics is if they have stones, we can potentially also treat those stones at the same time. And an option for stent placement or drains. And those options, so there are some questions about whether there's a lot of discussion about when stents are needed, what type of stents are needed, whether a drain is needed. I rarely, if ever, use a drain after these procedures, but especially when performed robotically. However, stenting is quite common. And stenting can occur in a variety of ways. We can have an external stent that drains to the outside, a stent that comes down to the bladder from the inside. We can have a stent that has access so it can be removed either in or out of the OR. And those are important things to discuss with your surgeon in advance to understand what the post-op course for your child will be. Any other questions? Okay, thank you so much for joining us. Please feel free to contact us, and there's our contact information. Thank you.